it's important that we have a common language, we professionals anyway, in talking about these disorders, because prior to around 1975, when the DSM-3 came out, people would talk about these disorders to each other and mean totally different things. And therefore, one psychiatrist said, well, this person has a schizophrenic reaction or whatever. It would mean one thing to him and something else entirely to the person he was talking to. Not a very good state of affairs, because you couldn't really have an idea of what the symptoms were or how long they've been going on or anything like that. And so in 1975, when I was in grad school, the DSM-3 came out, maybe it was 76, and it was really helpful. That was followed in the 90s by the DSM-3R, the revision, and then the DSM-4, which is the current diagnostic and statistical manual that all licensed professionals study hard. On every test for licensed professionals, they will ask you about diagnosis, and those questions are based on the DSM-4, and you better know it if you want to pass your test. That goes for psychiatrists, psychologists, licensed clinical social workers, MFCs, anyone with a license who wants to treat people with these disorders. And there are problems with the DSM-4 that are significant. But the problems with the DSM-4 is best talked about at another time, because it's a long topic. I can mention a couple of the problems with the DSM-4. It doesn't talk about etiology very much. It doesn't talk about treatment at all. It doesn't talk about defense mechanisms at all, which are important, and so on. On the other hand, it's way, way, way better than having nothing. Or DSM-2, which if you want to be entertained, I urge you to look at. It came out in around 1952. It is so vague as to be almost useless. And I don't think anyone studied it, because it just wasn't much of anything. But it's useful to look at, because that's what psychiatrists were supposed to use for diagnostic purposes until 1974. The DSM attempts to categorize these disorders according to symptoms, syndromes, length of time they've been going on, and so on. And they take a stab at defining what a mental or psychiatric disorder is, which is actually a good question, if you think about it. They kind of look at it as a clinically significant set of behaviors or emotional stressors that have been going on for a period of time, and how long that period is depends on the individual diagnosis. It varies all over the place, as I'll get to. And these symptoms, number one, cause distress to the person who has them or the people around them. Number two, they cause disability or impairment in functioning, so that when you are suffering from one of these disorders, you are not functioning as well as when you didn't have the disorder. And that's functioning in your job, functioning in school, functioning in your marriage or with friends. It causes impairment in those. And finally, it may also significantly, having one of these things, as they define it, may significantly increase your risk of pain, death, disability, or loss of freedom. And by that I mean being locked up in a jail or a psychiatric facility, which is a significant loss of freedom. One of the there's exceptions. One of the interesting exceptions is hypomania. Hypomania does not, they call it a syndrome, but it does not necessarily cause distressing symptoms or disability. Somebody with hypomania has a mood shift that's different from usual baseline. It has to last at least 4 days. And during that mood shift, it's almost as if you've taken some methamphetamine, but haven't. No methamphetamine or any other substances allowed for the diagnosis. If you have taken anything, sometimes prescribed medications can cause it. But if you've not taken anything, and you've had this mood shift for at least 4 days, you can be highly energized, need less sleep, have more goal-directed activities, etc., and not be disabled by it. Abigail wanted me to give some examples. So, one of my mentors who supervised me when I was an MFCC intern, he was the chief psychiatrist over at Kaiser in Hayward. Okay? He had a psychiatric disorder which would be classified today as bipolar disorder, NOS. He was hypomanic for a lot of the time. The time he felt normal mood was a minority of the time. So he was highly energized, would think and talk very fast, had a lot of goal-directed activity. They never got in trouble with it. And then, about 3 or 4 times a year for 2 days, he would have a crushing depression with suicidal ideation. Now, this does not count as a major or even minor depression because it lasted only 2 days. Okay? That's why it's bipolar NOS. But when it first happened to him, which was freshman year in college, he was suicidal during the depression. But he quickly learned that this depression was going to lift without any treatment within 3 days. And when I met him, this had been going on for about 25 years. All the time. Now, during those 2 days of depression, he could not work. But that's only 6 days out of the year that he couldn't work. And it was not really, it didn't cause severe disability, and he knew that he was going to bounce out of it, and he always did. So, by that definition, he really had and didn't have a psychiatric disorder. If you went by the DSM, he did have a bipolar disorder, NOS, not otherwise specified, but he wasn't disabled by it. So by their other criterion, he didn't have a psychiatric disorder. If you're not disabled, and you're not too distressed by the symptoms, and you're not at increased risk for those things I mentioned, that's it. No psychiatric disorder.